It'll probably come as no surprise to hear that the point at which a patient is admitted to hospital is the point at which a medication error is most likely to occur. And for those of you that have tried to do a drug history and found exactly how difficult it can be sometimes, I'm sure that that'll go a long way to explain why. There are a number of things that I see as a pharmacist over and over again that I think it's really important to be aware of, and there are loads of things that you can do to make that whole process easier and reduce the chances of those errors occurring. Now, the first scenario to consider is the one where you have a patient who's very thoughtfully brought the entire contents of their medicine cupboard with them. The best thing to do is go through with the patient, because ultimately they're the ones who are taking these medicines. So if you go through them one by one, speak to the patient, they'll be able to tell you what's going on. Have a look at the boxes themselves, because they'll be able to give you a lot of clues. It sounds really obvious, but make sure that it's the patient's name that's on there. The second thing to look at are the dates. So if you get some older medication, normally it's got a bit of a look about it. The box is a bit battered, the label's a bit faded and yellow. Those should be little warning signs to think, is this patient still taking this medication if it looks that old? Sometimes you get a patient sent in by a GP, and in those cases the GP will often very helpfully print out a list of all their medicines and send that in with the patient. So you think, brilliant. There's a couple of little pitfalls with those printouts that you need to be aware of. First thing is, GPs can be a little lax sometimes on the updating front. So when you're looking down that list of repeat prescriptions, what you want to look at is, when were these prescriptions last issued? There should be a column with the dates. So once you start looking down that and you start getting to items last issued 3 or 4 years ago, you can probably safely say that the patient doesn't take it anymore, or at least takes it very infrequently. The other thing to consider is that the medicines on that list will be the strength of tablets that the patient is prescribed. Now, some medications, and particularly things like furosemide, gliclazide, omeprazole, metformin, where the patient might take various multiples of different tablets and make up a dose. You really need to be careful about looking for the amount of tablets that the patient is taking and not just going off on autopilot and writing once a day, once a day, once a day, once a day for everything. The other thing is, don't just focus on the repeat medications. There should be some acute medications listed there as well. And that will give you a clue as to what's been happening recently. What changes has the GP made recently? Has the patient been given some antibiotics? Has a dose of something been increased or decreased? Have they been given some extra painkillers? And the other place to look is, sometimes you get a list of the last couple of consultations and the GP's consultation details. And if you have a look through those details, you might find little helpful notes about, oh, I've made this change to this medication. Patient's feeling a bit dizzy, so I've stopped their blood pressure tablet. It might give you a bit more thorough background as to what's been going on with the patient. Everyone's always really focused on getting the tablets right, and what often gets missed are those little extra bits and pieces. So things like the inhalers, the eye drops, the creams, the patches. Make sure you always ask your patients specifically about them, because patients often don't really think of those types of things as medicines at all. If you know from the history that you've got a patient with asthma or COPD, ask them about their inhalers. If you've got a patient with glaucoma, ask them about their eye drops. You know they're going to be there somewhere. Now, despite your best efforts, sometimes you will find situations where you just end up thinking, I haven't got a clue what this patient might be on. Try and phone the GP if they're open. If they're not, have a look in the morning. Ask your pharmacist if they're around. They are the experts on trying to unravel and get to the bottom of those sorts of situations. Ask the patient if they're compos mentis, have they got a list on them? Have they got a repeat prescription? Sometimes they might have a list on their smartphone. The other thing to look at is, Have you got access to a summary care record, the electronic smart card access GP prints, which are becoming more and more prevalent in hospitals now? That's an absolutely fantastic resource. Finally, who looks after the patient's medicines at home? Is it the patient? Is it the carer, their husband, a wife? Who might you be able to call who can tell you these things? We go to all this effort to make sure we get the patient's medicines right on admission. What we need to then do is make sure that we get it right the other end, and we communicate back to the GP, what changes have we made? What medicines have we stopped? What medicines have we started? Why have we started them? So often you find that things are stopped during hospitals and the GPs don't really get told why these have happened. And sometimes they do just assume, oh, they've been forgotten about. The patient gets restarted on them, and then it's no surprise that they get readmitted to hospital 3 weeks later, having been started on all the tablets that you diligently stopped the last time. Keeping records of what you've stopped and why is an absolute essential part of prescribing. It doesn't have to be detailed. It can just be a question of when you score something through in the chart, make a little note and say, low blood pressure. That's why I've stopped antihypertensive. And then you can, when you're looking through, doing the TTOs, you can pop that information into the discharge summary, everything gets communicated back to the GP, and the patient continues on the right medication when they go home. Also think about how long does the patient need to take this medication for, and tell the GP that. So if it's something that has a defined duration, so clopidogrel, say, is normally taken for 12 months, tell the GP that the patient needs to be on this for 12 months, and then they can put an alert in their system to review that medication at the appropriate time. In a similar vein, when you're prescribing an antibiotic, you need to be considering at the outset, how long does this patient need to carry on this medication for to treat the infection? So when you're prescribing an antibiotic, especially for an inpatient, and especially if you've got an IV antibiotic that you maybe just want to give for a day or two to get on top of this infection, write that down. Otherwise, there's a danger that the patient could just carry on that for a couple of days, and the next thing you know, you've got C. diff, and that could easily have been avoided. So you really need to make sure that when you're prescribing antibiotics, always include the indication and always include the review date on the prescription.